So Dr. Rexroad, feel free to just, if you have any questions, just feel free to chime in. I'm hoping it's, not a formal, it's just really you and I. So
yeah, I see that.
chime in if you have questions.
Okay.
So today I was going to talk about Myxedema, Coma, and Thyroid Storm. We can go to the next slide. Our objectives will be to define it, talk about some clinical presentations, diagnosis, and then treatment. Next slide. So Myxedema, Coma, what is it? And how is it different than plain old hypothyroidism? Basically, it's just on a continuum. So it's just a much more severe form of hypothyroidism where you will see decreased mental status, things like hypothermia, overall slowing of mentation and function of really all organ systems. It's a medical emergency with a high mortality rate of approximately 30 to 50%. So these patients should be hopefully in the ICU. Next slide, please. The epidemiology and risk factors. So elderly females are most affected. That comes from the fact that females in general have more autoimmune disease and are more often affected by autoimmune thyroid disease. This can be precipitated by an acute event in a poorly controlled or non-compliant hypothyroid patient. Some precipitants that we know of, infection, MIs, cold exposure, surgery, or administration of sedative agents, especially opioids. There is a possibility of precipitating infections. Any acute illness can tip a patient over the edge. Also understand that patients may not have a febrile response to underlying infections because, again, their metabolism is dampened. Next slide, please. Clinical features, as we talked about, but I just kind of want to put it in a chart form so that you can have it in your clinics. So decreased mental status is the number one thing I ask when I get consults for concern of myxedema, coma. We need to see decreased mental status or change in mental status. Hypothermia, bradycardia, hyponatremia, hypoglycemia, hypertension, and then precipitating illness or infections. Next slide, please. And this is a picture that shows peri-orbital edema. So our patients can have significant severe swelling from what's called glycosaminoglycan deposition under the skin. And so this can happen externally, but I also want you to remember that it can happen internally as well. And so patients that are in the ED with myxedema, coma, we really want to make sure they're protecting their airway, simply because this swelling on the outside also is swelling on the inside. So making sure their airway is intact. I also would like to bring up too that if you're considering the swelling on the inside, that if a patient is treated with their oral synthroid, they may not be absorbing it because they're going to have swelling of their bowel wall. Everything inside is swollen, so they may not be absorbing the synthroid or levothyroxine well. And so for that reason, sometimes we treat with IV. Next slide, please. These are just some more pictures of actual, patients that had myxedema, coma. You can see the peri-orbital edema, swelling. You can see hair and skin changes, very dry skin, nail changes, brittle nails. And then you can see in the third picture over the patient that has fully recovered, the difference in her appearance. Next slide, please. This is what glycosaminoglycan deposition and mucin deposition under the skin looks at. Like, it leads to what's called pretibial myxedema. And so that's another clinical clue that someone may be in myxedema, coma. Next slide, please. Some of the neurologic manifestations we can see: altered consciousness, confusion, lethargy or completely obtunded, coma, and even seizures. They can also present with very prominent psychotic features, and we refer to that as myxedema madness. Next slide, please. Hyponatremia occurs in about 50% of patients. It can be one of the contributors to mental status changes. And this is because of an impairment in free water excretion. We know that thyroid hormone helps excrete free water. Also, they can have excessive vasopressin in a severe hypothyroid state. Impairment in renal function may also be a contributor to their lack of free water excretion as well. And then in any patient that comes in with myxedema, we always want to consider concomitant adrenal insufficiency because autoimmune diseases can run in clusters. And so adrenal insufficiency can also lead to hyponatremia because it is another endocrine disease that affects free water excretion. Next slide, please. And hypothermia can be seen. This is just decreased thermogenesis due to a decrease in their metabolism overall. Remember, thyroid hormone is your metabolism hormone. So when we have a lack of thyroid hormone, everything is slowed. The severity of hypothermia related to mortality is related to their mortality, and a lower temperature equals a higher mortality. Next slide, please. So hypoventilation happens with, central depression of the respiratory drive. It can lead to respiratory acidosis, respiratory muscle weakness. You can have mechanical obstruction due to a large tongue. As we talked about, the swelling occurs both externally and internally. And this, you can have your patients tell you, I've had a sleep apnea and I just started really snoring only maybe 6 months ago. And that's another clinical clue that they may have tongue and neck or internal swelling from their thyroid, leading to obstructive sleep apnea. Airway management, as we talked about, is very important. And we can go on to the next slide. So concomitant adrenal insufficiency, as we mentioned, that autoimmune diseases run in clusters. So you can see adrenal insufficiency in settings with myxedema coma. And this may be manifested by low blood sugars or hypoglycemia, or just from the thyroid itself because of decreased gluconeogenesis, starvation, or infections that are concomitantly occurring with their severe hypothyroidism. Next slide, please. The cardiovascular abnormalities to look out for, so bradycardia, decreased cardiac output, hypotension, heart failure, which is more likely seen in the setting of existing cardiovascular diseases, and pericardial effusions. Next slide, please. To diagnose it, asking their history, doing a physical exam, and excluding other causes of coma. Thyroid function tests help to confirm your diagnosis. And then you want to look for on your exam just thyroidectomy scars or goiters, which will give you good clinical clues that there's an underlying thyroid issue. If their family is there, they're not able to speak to you. If they've had a history of radioactive iodine therapy, which would ablate and kill the thyroid, that's another clinical clue. And if they've ever had a history of hypothyroidism and you see Synthroid on their medicine list or levothyroxine. And patients that are in myxedema coma, I can't stress, we all know this, how important it is to talk to family and get collateral history, specifically a history of hypothyroidism or ever being on thyroid hormone.
You're on mute for a second, Dr. G.
Sorry about that.
No worries.
Next slide, please. There we go. So to look at labs, we would draw a TSH, that's the most sensitive marker of thyroid function, free T4, and a cortisol level. The serum T4 is typically very low or undetectable, and the TSH will be typically very, very high if it is primary hypothyroidism. And that's the most common pattern that we see. Understand, though, that there's two different types of hypothyroidism to differentiate. There's primary hypothyroidism, and I like to think about that. Primary disease is when you have something affecting the gland itself. So think about primary as at the level of the gland itself. Secondary hypothyroidism is at the level of the pituitary, and then tertiary, more complicated, could be the hypothalamus. So if the TSH is high, that signals that they have primary disease, and that's at the level of their thyroid, which is pushing their pituitary to put out more TSH signal. If their TSH is low, or it's, slightly high, like 5, but their T4 is undetectable, that's more of a signal that it's a central pattern, because your pituitary can't function to put out that TSH signal. So just because a patient may have a normal TSH, if they have those clinical clues of hypothyroidism, you want to just make sure that they're not experiencing, central hypothyroidism, and that we don't miss myxedema, because, our patients that have had brain trauma, brain pituitary surgeries, hydrocephalus or compression of their pituitary gland can be, at risk for central hypothyroidism that we don't want to miss. Next slide, please. There's a myxedema scoring system that can be found on UpToDate. And as you can see here, the patient is graded on a point scale, depending on the things that they have or don't have. And a scale of 60 or more is very high risk of myxedema coma. So I think that this is a good clinical guide when you're faced with, do I need to, number one, admit my patient for hypothyroidism? And number two, do I need to admit them to like the ICU? Do they have myxedema? And as you can see, I'm not going to read the whole slide for you, but there's temperature dysfunction, CNS dysfunction, any kind of GI findings, precipitating events that could be occurring, metabolic disturbances, and cardiovascular dysfunction. And that's what we use for our grading scale. Next slide, please. To treat myxedema, so after we've drawn all of our thyroid labs, we first want to make sure that we support the patient with steroids. And that's probably one of the most important tenets of therapy, because if a patient does have concomitant adrenal insufficiency and we give them thyroid hormone, what that's going to do is it's going to speed up their whole metabolism. And so they could go into an adrenal crisis because their adrenal glands can't put out enough cortisol to meet the demand of illness. So it's really important to first treat with stress doses of steroids if you have any suspicion of concomitant adrenal insufficiency. If they've been, hypotensive, if they've been treated with a lot of steroids, say that they have maybe asthma, COPD, or they have a history of steroid use for RA or something to that matter, you want to give them stress dose steroids and make sure we're not missing possible adrenal insufficiency. And then you can draw cortisol, but a cortisol level shouldn't delay you in treating them with empiric steroid therapy. Then you want to administer anywhere from 200 to 400 micrograms of levothyroxine IV, followed by daily doses of 50 to 100 micrograms. It is controversial to use triiodothyronine, or it's called T3. I typically do not use that unless they're very, very young, healthy patients without any cardiovascular disease. And if you do use that, it's typically 5 to 20 micrograms IV, and then you can follow that up by 2.5 to 10 every 8 hours following. But I typically use the levothyroxine, and if it's a younger, healthier patient, I'll go on the higher end. So 400 micrograms push for the first day, and then followed by 100 daily after that. If it's an elderly patient or somebody that has cardiopulmonary disease, I err on the lower side of that levothyroxine dose. So I give them 200 micrograms IV for the first day, and then follow it up by 50 to 100 until we see a rise in their T4 levels. And I typically check the T4 levels. Depending on the severity, you can do T4 level daily or every 2 to 3 days, and make sure that you're seeing a rise in their T4. We do not typically check TSHs because the TSH, remember, that's your pituitary signal. So when your bloodstream sees your T4 rising, it takes time for your pituitary to get that signal. And that time may be 6 to 8 weeks. So in the hospital setting, we typically check the T4 to make sure that's rising, because it's a more acute indicator of the day-to-day rise and improvement in the free circulating thyroid hormone levels. Supportive measures, we talked about some of the triggers of myxedema coma, so we don't want to miss underlying myocardial infarctions, infections, so treating them with empiric antibiotic therapy, ventilating them, vasopressin, all the supportive measures are very important. We can go on to the next slide, please. Monitoring, we discussed this, so monitoring the T4 every 2 to 3 days. And typically you'll see clinical and biochemical improvement within about 1 week time. The serum TSH, if it is drawn, should fall at a rate of about 50% per week in patients getting their full replacement dose of thyroid hormone. And once there's clinical improvement, we can see their mental status begin to improve, stable vital signs. If the patient's taking pills at that point and they're awake, alert, oriented, you can convert the IV to PO or oral T4 or levothyroxine. And the dose of T4 is typically based upon their body weight, their age, and whether or not they have cardiovascular disease. So typically an adult patient, it's about 1.7 microgram per kilogram daily. If the patient has cardiovascular disease, we usually err on the lower side and do 25 to 50 micrograms oral daily. And we just continue to increase it in 25 microgram increments every 2 weeks, making sure that they don't have chest pain or shortness of breath as we're increasing the dose. So those are the things that we take into account when we're giving them an oral dose. Next slide, please. So now we'll switch gears and talk about thyroid storm. So this is kind of, if you think about myxedema coma as the most severe manifestation of hypothyroidism, we switch gears to talk about thyroid storm, talking about the most severe manifestation of hyperthyroidism. It's rare. There's about 6 per 100,000 hospitalized patients per year. I'd say as an endocrinologist, though, it doesn't feel rare. I definitely see these patients in the hospital frequently. It can be life-threatening. It's characterized by severe clinical manifestations of thyrotoxicosis, which will go through those manifestations in depth. Some of the precipitants can be surgery, trauma, infections, acute iodine loads, pregnancy, or DC of their anti-thyroid drugs like methamisol or PTU. The mortality this carries is about 10 to 30%. We can go to the next slide, please. So some of the clinical features we see in these patients are racing heart, skip beats, tachycardia, heart failure, hypotension, arrhythmias, high temperatures, 104 to 106, we can see agitation, anxiety, mental status changes, specifically, you can see psychosis, and then nausea, vomiting, abdominal pain, jaundice. They can have severe weight loss from all of these symptoms as well. Next slide, please. Looking at their physical exam, you may see a goiter. Graves' disease can present with a goiter, although you do not have to have a goiter to have Graves' disease. The eye findings that we typically see, it's called ophthalmopathy or thyroid eye disease. You can see what's called proptosis, which is when your eyeballs push out more. You can see lid lag, and lid lag is defined by, so I'll try to do it with you guys. So if you see my pointer finger, I ask the patient to just look at my pointer finger and follow it with their eyes only up and then followed by down. And if you don't see your eyelid actually cover your limbus, which is the top part of your eye, then that is lid lag. So you should never have a white part above the colored portion of your eye or your iris like this. So this is considered lid lag. And you can see a hand tremor as well. Next slide, please. And this is a good kind of visual. As you can see, the lid retraction, this is kosher sign, and it describes kind of that deer in headlights vision, where it's like a frightened appearance of the eyelid and eyeball. And then the von Graff sign, you can see a retarded descent of the upper lid on down gaze, and that's considered your lid lag. As you can see, kind of the white portion above the patient's eye in the lower picture on the right, in his right eye, I should say. Next slide, please. And this is pretty significant proptosis. Again, this is when the eyeball pushes anteriorly. And so this can happen specifically in Graves' disease, when the Graves antibodies can affect the extraocular muscles and push the eyeball out at you forward. This can be, very distressing for patients with vision changes, blurry vision, double vision, dry eye, feeling like grittiness or sand is stuck in their eye. And so, just be mindful if you see these in our hospitalized patients to look for underlying hyperthyroidism. Next slide, please. And Graves also is associated with dermopathy. It kind of looks like that orange to Ptu type, looks like an orange peel on their, I typically see it on the lower extremity skin over their calves. Next slide, please. So in defining hyperthyroidism, typically we see a low TSH and an elevated T4 and or T3. And endocrine, I always like to think about endocrine as it's a series of feedback loops. And so let me get my paper here. I'm going to just kind of draw it out, so you have a visual to kind of think of whenever you're diagnosing thyroid. Can everybody see my art? I can't see myself in there. I just see the slides. So you guys tell me, can you see this?
Yes, we can.
I'm just seeing the slides. How do I get you?
Oh, Dr. Rexter,
Let's see. Why don't can you swipe on your screen to see the different people involved in the talk?
Dr.
Okay,
G, also stop share, and then we can see it that way, and I'll just reshare my screen.
Oh yeah. Let's try that. Great idea.
Okay. Gotcha now.
Okay. So do you guys see my little thyroid?
Yes.
Okay. So say your patient's hyperthyroid and they're putting out lots of thyroid hormone that they shouldn't be. These hormones are called T4, which predominantly is what your thyroid makes, and T3. So these levels will be so high that they feed back to your pituitary, and they tell your pituitary, hey, shut down shop. I don't need this TSH signal anymore. So that is why if a patient is hyperthyroid, their TSH is low, very low, sometimes undetectable, but their thyroid hormone in their bloodstream is very high. Their circulating free thyroid hormones, which are T4 and T3, will be very high, and their TSH will be very low. I like to think about endocrine, it's hard to look at it on paper, but if you draw it out, kind of what the hormones should do, it makes a lot more sense. And so we can go back to the slides, Mitra. Does anybody have questions on that? I think I get a lot of questions often about, well, my TSH is low and that should be hypothyroidism. And so you have to kind of think of it inversely. Hyperthyroidism is actually a low TSH and a high T4 or T3. And so the degrees of thyroid hormone excess, they're typically not more profound than you'll see with uncomplicated thyrotoxicosis or hypothyroidism. And so we'll go on further and I'll tell you how to actually diagnose thyroid storm, but it's actually not by lab work. It's by what your patient looks like clinically. And we'll go through that in depth in a minute. Some labs that you can see are hyperglycemia, hypercalcemia, and that's because of bone resorption. It causes bone turnover, high thyroid hormone, as you can imagine. your entire metabolism is going really quickly. And so your bones are also turning over, and that's what causes the high calcium. Elevated liver function test, you can see white blood cell counts or even leukopenia. It can cause, aplastic crises we've seen. Next slide, please. To diagnose it, it's based on the presence of severe and life-threatening symptoms in patients that do have biochemically confirmed hyperthyroidism. So I've been called about patients who meet all the clinical criteria of hyperthyroidism, but their blood work is completely fine. You have to have both a biochemical confirmed hyperthyroidism by the lab work plus the clinical symptoms to truly have hyperthyroidism or thyroid storm. Some of the clinical clues that you can see if your patient, isn't able to tell you is if they've had, any kind of recent surgeries, any exposure to iodine containing contrast. So if they've had recent CT scans, that can be a very high iodine load. If they've been on amiodarone recently, amiodarone is an incredibly high iodine content. Right now in the United States, there's a huge fad for like herbs and supplements. And so the one that's most common this year is called Ashwagandha. It is a supplement that's supposed to increase energy, and it has thyroid hormone in it. And so don't miss patients that they're on herbs or supplements for energy that are embedded with tons of thyroid hormone in them. I've seen heart failure and thyroid storm from just herbs and supplements. So be mindful of that as well. Next slide, please. So just like we had our scoring system for myxedema coma, we similarly have a scoring system for thyroid storm, and this is referred to as the Wartovsky storm score. This can be found on UpToDate as well. And if you kind of zoom in on the different markers, again, it's just like those bold point and myxedema markers. So you look at what's their temperature and how many points they get, what their central nervous system looks like. Are they agitated? Are they in a coma? And you score them on that. Do they have any cardiovascular or GI dysfunction? Do they have any heart failure symptoms? And then with thyroid storm specifically, the score of 45 or greater is more likely that they are truly in thyroid storm. So I think that this is really helpful when I have, residents and fellows with me, because we'll often get the call, my patient looks hyperthyroid. How severe is it? Do I need to send them to the hospital? Do they need to go to the ICU? And the two most important slides for you as clinicians are looking at the myxedema scoring system and the Wartovsky scoring system, because the labs don't tell the true picture of how sick your patient is. You really need an overall clinical picture, and that is guided by these charts. What is their temperature? What is their heart rate? Are they mentating okay? And these will tell you kind of the severity of disease and what you need to do from there. Next slide, please. To treat hyperthyroidism or specifically thyroid storm, understand that the therapy is also applied to patients that don't actually meet criteria for storm. So this is probably similar to how you're treating your patients in clinic, right? And so a beta blocker is used to control their sympathetic overdrive and their sympathetic symptoms. So to help them sleep, to slow down their heart rate and all that sympathetic nervous system overdrive. The thiamides, these block new thyroid hormone synthesis. So they're really not going to do anything to bind the abundance of thyroid hormone in their system, but it will prevent new thyroid hormone from being made in their thyroid. Iodine solution, you probably hear of this as it's called Lugol's solution in your hospital. And we typically give this to block the release of preformed thyroid hormone from their thyroid gland. And usually the patient will escape from that effect after a 5-day period. So it's really short-lived that we use iodine solution. If we give iodine in a bulk amount, it will have the effect of shutting down the release of thyroid hormone, but over time, if we give it for long periods after 5 to 7 days, the thyroid gland will begin to use that thyroid hormone to convert and put out thyroid hormone. So again, that's a very short-lived treatment. We use glucocorticoids because they reduce the conversion from T4 to T3. I had told you earlier in my little drawing, you remember that I said the thyroid hormone mainly puts out T4, and then it gets converted to T3 at the organ. And so the T3 is a very potent form of thyroid hormone. And so we're always trying to block the conversion from T4 to T3 in hyperthyroid patients, and steroids do that. It also helps with, blood pressure control and stability in patients who may be, severely hypotensive or in shock. And then steroids also help to treat potential concomitant adrenal insufficiency. We mentioned that autoimmune diseases run in clusters. And so if your patient has autoimmune Graves' disease causing their hyperthyroidism, there is a chance that they could have concomitant adrenal insufficiency. And so steroids really hit all of those at once. We use bile acid sequestrants like cholestyramine, because what that does is it decreases enterohepatic recycling of thyroid hormone. So they bind it in their gut. It may have diarrhea or flatulence in eliminating the thyroid hormone, so it can't be reuptaken and circulated through their system. Next slide, please. So does anybody have any questions? Okay, so beta blockers, to go in a little bit more depth. Propranolol is the beta blocker that actually is recommended in a hospital setting in Storm, because propranolol does have some activity as a beta blocker in decreasing conversion from T4 to T3. So that one is more commonly used. And we titrate that to a heart rate of around 60 to 80. In the outpatient setting, I typically use atenolol because of ease of use. But in the inpatient setting in Storm, we use propranolol more commonly. And then propylthiouracil or PTU or methamisol, those are your thioamides. And again, they block new thyroid hormone production. So I'm not going to read the doses to you. You can find them on Up to Date. I simply just want you to know those two to be aware of. So PTU and methamisol. More commonly, we do use propylthiouracil or PTU because that works like propranolol, and it decreases the conversion from T4 to that very potent T3. So in Storm, we use PTU. Outpatient setting, more commonly methamisol for ease of use and compliance. In the inpatient setting, 1 hour after the first dose, after you've given your thioamide, then you can give your SSKI, your Lugol's, your drops of iodine, because you want to prevent that Lugol solution as being a substrate for them to make new thyroid hormone. So we first treat with methamisol or PTU. Once that's in their system after 1 hour, then you can give your SSKI or your Lugol's to prevent the release of thyroid hormone from the gland. Steroid dosing, we typically give hydrocortisone, 100 Q8 or 50 Q6. Basically, it's stress dosing. And then bile acids, the cholestyramine is typically 4 grams, and we spread it out 4 times a day. It's typically one of the harder therapies because, again, it causes bloating, flatulence, and diarrhea. Next slide, please. We monitor the levels of thyroid hormone and expect the levels of thyroid hormone to change after about 45% after 24 hours of PTU. So we want to see that free T4 come down by about 45 to 50% in 1 day after therapy, and about 10 to 15% within about 24 hours after methimazole use. So PTU should be converted to methimazole before your patient's discharged from the hospital, because again, methimazole is easier to use. It has a longer duration of action. It has less hepatotoxicity. So most of the patients that you'll see with hyperthyroidism are on methimazole for that reason. The exception of that is pregnant patients in the first trimester only will be on PTU, but most other patients in the outpatient setting, methimazole is your go-to. Next slide, please. If your patient is intolerant to methimazole or PTU because of liver toxicity, agranulocytosis, or allergies, the other therapies that we can consider are thyroidectomies, plasmapheresis, or remember your cholestyramine or your bile acid binder that binds at excess thyroid hormone in the gut. Those are all alternative therapies. Next slide, please. After clinical improvement, improved status, stable vital signs, we hold those iodine drops. Remember, only 5 to 7 days, and then we hold the glucocorticoid or steroid, typically within a few days, just like a typical stress dose steroid course. Beta blockers are DC'd after the thyroid functions have normalized. And then the dose of the thiamide is titrated to maintain euthyroidism. And a lot of that occurs in the outpatient setting on follow-up of thyroid hormone labs. Next slide, please. Do you guys have any questions about anything that we discussed?
No questions, but I have to say this is such a beautiful photo. Oh my
Oh, thank you.
I love this. I'm gonna keep it up for a little longer so we can all appreciate it.
Yeah.
But no, thank
Actually,
Purple.
I do have a question going back to the myxedema for a minute.
Yeah.
Over what kind of time period does this usually develop? I mean, are we looking at something that happens over days or weeks or?
Yeah. So in my experience, I found that patients may stop taking their thyroid hormone, or say they live alone or forget to take it, or for whatever reason, they stop taking it. And then they slowly decline. They gain more weight. They have the, pretibial edema. Their family member starts noticing they're forgetful. They're not functioning. And then they have a precipitant, usually say they get the flu or an upper respiratory infection, and that will just throw them over the edge. So they can be having a slow, steady decline over months. A lot of people will say, well, I stopped my thyroid hormone 6 months ago, a year ago, and I didn't feel well. I've gained 100 pounds. Wasn't really thinking clearly. But then they have something that really hits them, like COVID or an MI or some kind of trigger that really just puts them over the edge. So it doesn't have to be, in a 24-hour period or overnight, especially in people that have some degree of endogenous thyroid function. Say they have like autoimmune disease and their thyroid is still putting out small amounts of thyroid hormone to just kind of keep them going. Patients that have had a thyroidectomy, on the other hand, from thyroid cancer or thyroid nodules, they don't do as well because they don't have they have nothing, right? They don't have even a trickle of thyroid hormone. They have zero. So those patients, if they stop taking their thyroid hormone, typically go into myxedema and do much worse if they stop their drug.
Okay. I was just curious about that because it seemed like it was pretty drastic. And did it happen all at once? And I was scrolling through the chart of one of our nursing home patients who kind of crashed last week, and we were trying to figure out why, but her TSH was normal. So.
Yeah, well, in that case, you might want to check her for ET4 because remember, we don't want to miss, secondary hypothyroidism, where your TSH could be normal, but the free T4 is low. So in those cases, I try to think, do they have a history of brain trauma, brain surgeries? If they're an athlete and they've had concussions, those are signals maybe that they could have central hypothyroidism. Also, patients that have kind of infiltrative diseases like amyloid, sarcoid, they can have extension and infiltration of their pituitary, so their TSH would be low as well. So if you have those clinical symptoms, you can always add on a free T4 to just make sure that they have adequate circulating thyroid hormone, that we're not missing secondary or tertiary hypothyroidism.
Thanks.
Of course. Does anybody have any other questions?
Yeah, along the same line, okay. We always worry about that Myxedema coma, but I have never personally seen it. But I do see patients, I mean, either with memory problem or due to the non-compliance, their TSH could be 50, 80, 90, those kind of things. And because they are asymptomatic, I usually don't like push them for ER or anything, but because they are asymptomatic. So I try to treat them. And I know you told about clinical presentation, not just the lab value. But is there any TSH value that, okay, if we see, then we need to be aggressive or closely watching them? Because even when we start the thyroid hormone, there's no point in checking it unless it's 6 weeks or 2 months.
Totally right. With everything you said. You know, if your patient is feeling fine and they're clinically stable and their TSH is 50, most likely it's been 50 for like months preceding that. So there is no urgency in treating that. And that's why, you know, in my presentation, I said the two most important slides to help guide you in clinic are the Myxedema Coma scale, where it gives you, did you see that Myxedema one where it gives you like the scoring system greater than 60 or more? And then the Wartovsky Storm score for hyperthyroidism, a score of 45 or more. That will help guide you to get the clinical severity, because Thyroid Storm and Myxedema Coma are not diagnosed based on labs. Many people are hypothyroid and hyperthyroid. It's only when they have those clinical criteria that we need to admit them to the hospital. And you're absolutely right about doing your follow-up testing. So thyroid hormone has an extremely long half-life. And so we recommend, if we change a dose or increase the dose, then we check the next dose in 6 to 8 weeks time. I don't typically follow the TSH in those cases. You'll check your T4 and make sure, and I check a free T4 typically in 6 to 8 weeks time and make sure it's coming up. And then once you have a free T4 in a normal range and your TSH has come into the normal range, you can stay on that dose and just, you know, check another lab in 8 weeks and then space it out to, you know, every 6 months. The things that really affect the delivery of thyroid hormone are things like, you know, if you have a patient that has celiac or malabsorption issues or a history of bariatric surgeries and malabsorption, or IBS, any kind of GI things where you would suspect malabsorption, you can check it, you know, more frequently.
Thank you.
Of course.
Questions or comments from anyone?
I don't know whether you can talk something about subclinical hyperthyroidism.
Yeah. We can certainly do, you know, a teaching session on that, but just in general. So subclinical just some basic points about it. Subclinical hyperthyroidism is defined by, it's biochemically. So that is a biochemical diagnosis. And subclinical hyperthyroidism means that you have a normal T4 and T3 with a reduced TSH. So your circulating thyroid hormone levels are normal. You just have a mildly low TSH. And if we go back to that picture that I drew, your thyroid is putting out slightly high doses of T3 or T4 or both. And it's feeding back to your pituitary saying, hey, I don't need as much of a thyroid stimulating hormone or TSH signal. And so the TSH is low. when we talk about treating subclinical hyperthyroidism, it's biochemically as well. So if your patient's TSH is less than 0.1, you treat it in everyone. Less than 0.1. If your TSH is 0.1 to 0.5, you treat it if they have comorbidities. If your patient has osteoporosis, AFib, any kind of cardiovascular disease like heart failure or coronary artery disease, and you don't want to risk them being hyperthyroidism and it exacerbating their disease, then you treat it. I have patients who may have uncontrollable anxiety and restless leg. I treat it. So from TSH of 0.1 to 0.5, there's wiggle room. If they have comorbidities where you feel like it would help them, treat it. If the TSH is less than 0.1, always treat it. Doesn't matter what their comorbidities are. Doesn't matter what their age is.
Thank you.
Sure. Yeah, there's a lot of good data out of Europe. It's by, if you're interested in looking up some of the hyperthyroidism data, specifically subclinical hyperthyroidism, it comes from Dr. Biondi's group, and it's from Italy. And they had done studies in young patients with subclinical hyperthyroidism, and specifically kind of looking at the cardiovascular transformation of subclinical hyperthyroidism. And so from that data, it was shown that subclinical hyperthyroidism can cause cardiovascular remodeling, even in young patients. And so we have guidelines where, you know, if the TSH is less than 0.1, we treat it. 0.1 to 5, consider treating it. But Dr. Biondi's group has put out extensive amounts of data on specifically subclinical disease.
I mean, most of the time, I usually take help of endocrinologists. It's, of course, if they're not clinically symptomatic, it's not urgent. I know that. The only thing I come across when the patients are not keeping up with the appointment or they don't want to go, and I want to keep monitoring, that is where it becomes a little bit tricky.
Yeah, and I'm truly hoping that, I think that COVID has changed the delivery of healthcare a lot. And so I'm hoping that telemedicine visits, video and phone visits continue to be reimbursed by insurance, because you're right, there are a lot of patients who can't come to see an endocrinologist or don't want to, you know, make the trip or take off work or have children that they can't bring to their appointments. And so I think that having video and phone visits has really revolutionized the ability for patients to see specialists more easily. So I'm hoping that that really does continue throughout COVID and beyond COVID.
Do you recommend screening for hypothyroidism? You know, we get these people who come in from health fairs and they've had a TSH, and it's a little out of whack one way or the other.
Yeah, typically we don't screen. It's kind of like a case finding, but I'll tell you, like, most people get a TSH for, we could go on for billions of days why people get TSHs, you know, hair, nail changes, weight changes, fatigue. And so I feel like it's kind of become a regular part of a routine panel. But we typically don't just screen everyone for a TSH. We do kind of a case finding. If they're symptomatic, then we would order it. Yeah.
This has been such a great session with awesome discussion. Thank you all so much for the questions as well. And thank you as always, Dr. G, for a wonderful presentation.
I got to run to a clinic, so.
Absolutely. Thanks, Dr. Rexford. We'll see you next time.
All right.
Bye. And if there are any other questions, as always, feel free to shoot Elizabeth and I an email. We'll make sure to send it over to Dr. G, or try to have it addressed in any way. We're always here to help. So We do encourage case submissions as well. It doesn't have to be a full-on case, just even a question you want to input in the case form. That would also be super excellent.
Can I ask one question?
Absolutely.
I mean, it is different than the topic. Okay. Now, when you come across a situation, for example, if the patient is on Ozempic 1.5 milligram or on Victoza 1.2 milligram, and the insurance stop covering that, and then they say, no, don't give Ozempic, give them Trulicity, or they cover something else. Do you do the conversion like from Ozempic 1.5 to Trulicity 1.5, or do you start again from the basic, like Trulicity 0.75, and then you keep increasing the dose over the time? The same thing Victoza, if they're on 1.2 milligram, 1.8 milligram daily. And when
Right. I know what you're saying. I think all of us have that problem because insurance changes with the weather. So we all have to deal with different drug changes. And if they're on a low dose of their Victoza or their Trulicity, then I'll just start the low dose of Ozempic. If they're similarly on the highest dose of Trulicity, I'll just go to the highest dose of Ozempic, and I'll let them know, you may have some symptoms as we change to a different drug. And so the symptoms to watch out for with your GLP-1 receptor agonists are always going to be nausea, vomiting, GI distress, worst case scenarios, pancreatitis. And so I just tell them, please let me know if as we switch drugs, you have any nausea, vomiting, cramping, and those sorts of things. And if they do, just back down the dose. Say they're on Ozempic 1 milligram is the highest dose. You can just back down to Ozempic 0.5 and then gradually titrate it upward.
Okay, thank you.
Sure.
And Dr. Pollywall, it never has to be always related to the didactic. Any questions you have, we love it. So thank you for that. Alrighty, any other comments, questions from the group? Alrighty, well, big thank you, Dr. G, for another great didactic. I only have one announcement. So Dr. Giordano will be presenting again next time on May 26th on common medications and when to use them. So keep an eye out for that reminder. Dr. G,